Welcome, one and all. My name is Anna Lomprier, and I am a wayfinder. I work for the Cornwall Memory Cafe Network, supporting carers and people living with dementia to access services, make referrals, and really help them find a way to get more support. This is part of Disability Cornwall, and we've decided to create this podcast interviewing experts and people with lived experience on dementia to be able to share all sorts of interesting and informative and supportive information. So sit back and enjoy, and also share the podcast with your friends. It's relaxed and inclusive and welcoming, and thank you for listening. Welcome everybody to our Dementia Toolkit video series, a one-stop shop answering all your questions on everything dementia related. Simple educational advice from people with lived experience and professionals in their field. We aim to provide support that's personalised to help you on your dementia journey. Welcome everybody. We're really privileged here to have Paul Cadger with us today, who is the lead of education for dementia in Cornwall, across Cornwall. And so we wanted to talk to you today, Paul, about falls and everything there is possibly to know about falls, how people might prevent some risk and get support and all that sort of thing. So it seems like a really obvious question, but I think it will open up a good discussion. What is a fall then? What's considered a fall? And welcome.
Thank you very much. Yeah, I'll do my best. I'm a physio by background, so this has been like a big part of my job before becoming a Dementia Education Lead. So a definition of a fall is usually what we classify as somebody who drops from one level to another unintentionally. So a really good example for that would be walking along, I went unsteady and I dropped down to one knee. I would classify that as a fall. Say, for example, I'm in my bed or I'm sitting in a chair and I slip out because, again, it has to be unintentional and come down to the ground. I'd classify that as a fall as well. It's really interesting because sometimes when I talk to people, I ask them when I do my physio role, like, have you had any falls in the last year? This is a really, really good common question we ask. And they'll say no. And then I'll carry on, we'll see them, I'll see how they're walking, go, you look really unsteady. And they'll tell me about the time they tripped over. And it's because we don't use the same language and the same words. So falls, but I'll come into other key questions that we ask. But falls is anything that drops from one level to the other that's unintentional. We add on a few other things. So, for example, it can't be from a major intrinsic event. So say, for example, I had a seizure where I've had an epileptic fit and I then come to the ground. That's not a fall. There's something that's happened, like a heart attack or a stroke, that's caused me to drop from one level to another. But we would include, this is a really common one, things like collapses. So say, for example, really common one is I stand up, I feel quite dizzy, and I then, I can't remember what happened to me. I just woke up on the floor. That would be something that's really good information. You can tell any healthcare professional thinking, right, if somebody tells me that, I need to look more at the heart. That's what's usually causing that dizziness, that what we call loss of consciousness. Whereas say if you said to somebody, I was putting out my washing and I turned round and I then fell to the floor, that gives me an idea of I'm thinking probably looking at balance, I'm looking at strength. So it's a really good way of thinking, right, this is how I've fallen to somebody. And it's kind of helps the diagnosis, what's going on to cause these falls.
Brilliant. And then I suppose then you can look at the different support and pathways to get that help.
That's it, yeah. So your first contact I would always go is to your GP, or if you've got a district nurse coming out to see you, or your dementia advisor or primary care dementia practitioner, tell them. They will know people. I think that's one thing good about the NHS and healthcare. We might not know ourselves, but we will know somebody who does, and that will be a priority for them to come and sort out. So if you tell one of us, it should get down the line, but always have a chat with your GP as well.
Thank you. All right, so then we're speaking on behalf of the Cornwall Memory Cafe network and people that are carers or people living with dementia. So is there more risk? And what is the risk? Or can you talk to us a little bit about that as well, and
Oh,
falls?
indeed. So if you were if you didn't have dementia, but you were over the age of 65, you have a 1/3 increased risk of falling than somebody who isn't. So just being older than 65 is a risk in itself. Now, I said that 1/3 of over 65s will fall. Now, if you had dementia, that goes up to 2/3. So exactly. So it's a huge problem, isn't it? It's a huge problem. And one really interesting thing I found out recently, they did a study in Australia of anybody living with dementia who presented to hospital with an injury. They found 90% of all injuries that went to hospital was related to falls. So it's a huge problem. Yeah, exactly. And nobody wants to go to hospital.
Wow. Yeah, that is a
Indeed.
lot.
So with the body, so this is again, we go back to that aging process and not dementia diagnosis. So the aging process in itself, I swear, I think when you're in your 40s, that's when everything starts to deteriorate. Even I remember doing like in science, you did that, you had to catch a ruler really quickly, and it had that light track test, and it tested your reaction speed. At 18, our reactions start to slow down. So as you get older,
Wow.
exactly. So when you when people say, why do some older drivers drive slower, that's how they compensate. They don't have to rely so much on their reaction speed. They drive slower, so the reaction times slow down. That's one thing. We have muscle fibers, and our muscle fibers change as we get older. So our strength muscle fibers, we've also got like endurance muscle fibers, but our strength ones, they start to deteriorate a lot quicker. So we need to work on our strength more than our endurance normally. Other things, eyesight, I think that is the last thing to go, about 40 odd. Hearing starts to go, and all these things, they affect how we interpret our environment, how we stabilize ourselves. Toileting, unfortunately, having to go to the toilet at night time. Urgencies are one of the big problems as well. Like if you've got toilet urgency, like have to rush to go to the toilet a lot, that increases our risk of falls. Lots of things with regards to aging. Another interesting fact, I think, was if you had dementia, you were more, like 90% of people with dementia have another like chronic disease or another impairment. I think I'm only 42 and I've got two chronic. I've got psoriasis and now I've got like blepharitis in my eyes, which is a problem. So as we get older, we pick up a lot more conditions, and the more conditions we have, that also affects our ability to do normal function, normal things to do and move about. If we have more medications, so the more medications we take, more than 4 medications will increase your risk of falls. And it's not just how the medication reacts with you, it's how they react with each other as well. So having more than 4 I know
That is fascinating, isn't it? So you've got this
it's
kind of chemistry going on inside of you. Yeah, that is
indeed.
impacting your, like you were saying, like your balance, your ability to respond. And I was thinking when you were saying about going to the toilet, it's navigating all the clothing,
Oh,
all of that sort of thing, isn't it?
yeah. So yeah, if you arthritis again, and we in what you're wearing, so yeah, it might be difficult to undress your trousers. So therefore, you rush. Like my
Yeah.
granddad had Parkinson's disease and Parkinson's disease dementia. Like I think in a month he would fall about 14 times, and probably 12 of them were in the toilet because it's that rushing to get to the toilet. It's that small environment. Say if you've got like equipment, like a stick or a frame, and you've got this small to try and turn around in, it can be really,
Yeah.
really challenging.
Yeah.
Um, yeah, so as we get older, we got more risks. But if you add on dementia as well, so it's really important when you say, I've got dementia, we know there's over like 200 different types of dementia. Each one of those will have different problems. So if you were to look at the human brain, if you had so I'm left-handed, which generally means my right side of my brain is more dominant because that does the muscles on this side. So if I had more, say, Alzheimer's plaques on the right side of the brain, and it was to do with like my leg function, so that'd be about here, down here-ish. That might make it more difficult for me to coordinate my muscles to stand up and move.
Yeah.
If you had it more, say, the back of your brain here, like a posterior cortical atrophy, that might have more of an impact on this, what we see that travels from here, our eyes, goes to the back of the brain, and how does that then interpret what we see? So is it like that change in color, or is it even a change of shape? So the different type of dementia will change the risks for you.
Yes. Wow. And that's making me think of when I went to the dementia conference that you organized, where there was somebody talking about really kind of like state-of-the-art care homes where they recognize that people living with dementia have visual changes. And so certain things are created, like certain flooring and wallpaper and doors that are conducive to that, more sort of stability and visibility.
Definitely. There's that we could look at. What I'll do is we'll put in the comes up with like, how can you look at your environment? So if you're looking at contrast, there's a really good one. So we should have contrast between, say, the toilet seat and the ceramic, so you can tell like the toilet seat's up or down. So usually a ceramic's quite white, isn't it? So therefore you want a dark black or a blue. I chatting to an optician, they said red is usually the last color that we'll lose. So you don't really want a red toilet seat, but you could, exactly. It's what you're thinking. How can you contrast with things? So if you had a handrail on the wall, you would want that to contrast with the wall.
Rather than all matching whites and
exactly. And it's really common, isn't it? Is you'd usually have a white light switch on a white wall, so it's really difficult to navigate. Interesting and easy thing you can do. So if you don't have a vision impairment, is how can I see if contrast is a problem? Get your phone, you can put it on black and white and take a photo. If you cannot see a difference between the two, it means there's lack of contrast, and that's something you can do. It doesn't mean it's a quick and cost-effective thing you can do, but it's something that you could then go, oh, look at that, and we'll come back to that, or we'll do something about that.
And it's those small things potentially that could make a big difference for somebody.
Exactly. And I'd think about, like, where am I falling? So with as I said, my granddad was in the bathroom. So you could have a look and say, right, if our main issue is the bathroom, well, what can we do here? Well, this is our biggest priority, because a lot of people go, this is my home. I don't like changing things about my home. So it's like, what do you want to change? And what you could do is give somebody like a list and say, look, if we want to reduce your fall, because it's very rarely, if you are falling, that it's just one problem. It's usually lots and lots. There are over 400 different risk factors for somebody falling over. So you can't just go, oh, I'm falling over. For me, I'm going to come see you today, and I'm just going to look at your muscle strength or your balance. You have to look at everything, from like looking at your feet to your eyes, to your feeling in your body. So can you feel when you touch the floor, or if you lost that from like a diabetes or from peripheral vascular disease, where you've lost the sensation in your feet? So there's so many exactly. There's so many things we need to look at, and that's why it's like, when you say to a healthcare professional, it might not be there, or I might not know much about it, but I will know somebody who does, and they can do a full, thorough investigation.
Wow. So there are over 400 different potential risks of falling. And that, to me, what you've just said is like, I didn't even have that thought. What a really clever thing that seems so obvious is, where are you falling? What is there somewhere that it's happening frequently in the same place? That just seems so obvious, but brilliant.
Is there a pattern? Is it a time of day? Is it location? Because you want to build up that bigger picture of like, where is it that we can stop? Is it in the garden? What can we do about the garden? There's quite a few things out there. If you're looking at environment, there is the Alzheimer's Society, on their publications, have a how can I make my home dementia friendly, and the University of Worcester and I think the King's Fund created a how to make your garden dementia friendly. So we really need to keep people engaged and doing things they love, so you can look at how to make things dementia friendly in your own little sphere. And if you've got the influence, like we do, Anna and I, we can then go to, all right, this local council building, let's see if we can make this more dementia friendly. The GP surgery is more dementia friendly. So how can we make our towns and where we live more dementia friendly?
Yes, exactly. And there's a big drive for that, isn't there, across Cornwall?
Oh yes. And at the conference this year, we're going to get It's a charity called CEPL 12. So Community Enterprise PL12 is their postcode to come and talk about how they've made Saltash dementia friendly.
Wow. So
Indeed, yeah. That'd be good. I'm
that's
hoping
incredible.
they've provisionally agreed. I don't want to, yeah.
Fingers crossed.
Exactly.
Because
Yeah. It'd be great.
if each little village or different spaces can do that, then and yeah, I think that's brilliant. There was something else I was going to say and it's gone for a moment. So dementia, you were saying about care homes. Let's go to care homes. So it seems like in care homes, they've got everything set up.
Indeed. So do you know what we were saying about that 400 risk factors?
Yes.
You're reminding me now of where we were going with this. I've gone off on track, haven't I? So what we do, say if I'm so there's 3 key questions to say, like, have I had a fall in the last year? If anyone says yes to that, we should be thinking, okay, I need to send you to somebody who specializes in falls. What can we do? If you were to say, do you feel unsteady when you're standing or walking? That would be another tick to that box. We'd need to send you that. Do you know what I said earlier when I asked that person, have you had any falls last year? They went, no. And then they told me they had a couple of trips. These are 3 key questions you can ask instead. So have you had a fall in the last 12 months? Do you feel unsteady when you stand or walk? Or do you worry about walking? So those 3 are the key questions. There's a little bit more snap to it than the do you have you fallen in the last 12 months? It's a bit more we call sensitive, so I can make a better identification. If they do, then that's when we would do something called the multifactorial falls risk assessment. So as I said, you're going to try and get as many of those 400 risk factors and look at them, because you're then going to go through them and go, okay, so I've highlighted that vision is a problem. So I'd be then going, right, so when was the last time you went to an optician? So it should be every 12 months. Are your glasses nice and clean? Really simple things like that. But it would be, that's a problem. Let's look at that. If you had poor foot health, say, for example, you weren't able to reach down anymore and look after your toenails, you think, all right, so how are we going to do that? If you've got a family member that can do that, or do I need to have a podiatrist? So if you were to be admitted to hospital, you would have one of those done. If you were to be admitted, or if you were to say, I want to live in a care home now, or if you went to, in Scotland, they do it. If you even went to a day centre to the care home, they would do it. But I don't think the rules are the same for England. But if you were to be a new resident at a care home, they would also have to do a falls risk assessment. It's not the same if you lived in your own home. And I go back to, I said 2/3 of people with dementia will fall in a year. That means 1/3 won't. So if you were looking at Cornwall, we have 10,000 people supposedly with dementia. 300 of those, it'd be a waste of time. So it wouldn't be, they're not falling, so we shouldn't be looking at it. It'd be a waste of clinical time. Whereas 600, we should be looking at. They're the ones that are falling over. They're the ones we can do something about. Wow. So that's why it's really important. Who are we doing these assessments on? How can we, if I was to do something for yourself, Anna, you're like, is this irrelevant? Why is he coming to see me about this? It doesn't make sense. You're less likely to switch off and not really engage. Whereas if it does make a difference to you, we can do a lot about it. And you're like, oh, I want to change the way this is in my home, or I'll do this now because I've shown that will reduce my risk of falling and don't want to fall again.
Yeah, and the thing is once you've had that fall, that's when things can deteriorate quite quickly, can't they?
So rapidly. It's quite shocking. So if you were to fall over and get back up within 10 seconds, they've measured this, so people, what the effects are. You're thinking that's going to be a knock to your character. You'll be a bit more brazen of it. If it takes more than 10 seconds up to I think it's 10 minutes. No, it's not like a couple of minutes. They know that, say, for example, I was hanging up my washing at that time. I'm not likely to go back and do that. I'm going to be more fearful. I'm going to stop doing the things that I need to do or enjoy doing because I've had that fall and I've had that difficulty of getting up.
Yeah.
So that's really, really important that we can.
That's massive, isn't it?
And then when you don't do, it's like a whirlpool. It's what do they call it? It's not a whirlpool.
Downward spiral.
Downward spiral. That's the perfect explanation. Yeah. So say, for example, I've fallen over doing my washing up, putting on the line. I'm not now going to go and do that washing on the line again. So I'm probably going to get weaker because I'm not going to go outside more. My muscles then don't get used as much. They get weaker. My confidence goes down even more. And then I'm slowly going down this little plug hole, as you say, because it's affected my confidence. If you don't use your muscles, you will lose them. And then you get weaker. And it just keeps going, because the next bit would be, I'm not going to climb the stairs. I'll stay downstairs. And the next thing would be, I struggle to get out of my chair. So I'm not going to get out of the chair. I'll get rise recline chair. And you see how it just
absolutely. Yeah.
It's
like your
slow.
world gets smaller, doesn't it?
Yeah. And it's a slow process sometimes. So it's really difficult. So they say with like a heart attack, that big shock to somebody, oh my God, I've had a heart attack. I'm going to change how I live because it's a big shock. Whereas something that's slow and progressive, you don't have that same, I'll change the way I live. And a lot of us are like, that's a future me problem. I'm not going to worry about falling over. That's a future me problem. Even if somebody falls over, they will still say, I'll leave that to that person 6 months down the line. But leaving it 6 months down the line just makes it so much more harder to come back from.
So that's fascinating. It's so interesting. And so your advice would be then, if someone's falling, is like having the heart attack, is to take the bull by the horns and say, right, let's find out what it is, and let's, change the environment, but also see your GP and be put down a certain pathway of a specialism, depending, and see how you can build your strength again. And
indeed, even before you've fallen, if you have a worry, there's a test. If you I'll show you, it's called the timed up and go. So if it takes more than 16 seconds to do this, it puts you at a risk of falls. Right? Shout at me if you can't hear me. So I am sitting down in my armchair. Yeah. My arm has to have arms, so I'm going to stand up. My clock is now started. Boom, 16 seconds. I'm going to walk 3 meters forwards. I'm then going to do a 180-degree turn. I'm going to walk back to my chair. I'm going to do another 180-degree turn, and I'm going to sit down. I'm going to stop the clock. If it takes more than 16 seconds to do that, that puts you in that category again. I need to do something now to reduce my risk of falls. Okay. So it's a real quick one. So if you're worried about it, doing that quick test where you stand up from an armchair, 3 meters forwards, turn around, 3 meters back, sit down, more than 16 seconds. Get in there fast. Just try and stop yourself from falling. And there's so many things you can do.
Yeah, so many things. So tell us what some of those things would be then. So if you've heard our video and you think, right, I'm going to do the test on myself or on my loved one, and you're not making those 16 or your 16 seconds or over, what would you recommend people
First, want to have a chat with your healthcare provider or your GP, because that would be the starting line. So I'm worried about falling. If you want to go in there and say my timed up and go is more than 16 seconds, they're going to be, whoa, this person knows what they're talking about. I'm going to do exactly what they say. But so you want to start the ball rolling. So it'll be the multifactorial fraud risk assessment. Might be a bit too early, but you'd look at things like, okay, the medications. What medications is that person on? Are any of them causing them to be, if you have dementia, to increase the risk of confusion, because it does happen with medications, but also your risk of falling. You don't have to speak to your GP about that. A pharmacist is just as good, or your district nurse if you're housebound. My go-to would be like a strength and balance exercise program. It's the best one out there we know of is the Otago. It's got lots of evidence behind it. But when you have somebody with a cognitive impairment like dementia, the evidence isn't as good, because we know giving somebody like a sheet of paper and stuff to do it's not person saying, no, I don't want to do that. So if that was say, for example, my granddad, and I knew he used to love going out like into the country to walk or walking the dogs, that's what I wanted to do. So that's something that you feel motivated and you enjoy doing. We need to keep you active and engaged in that. So things like if we start having barriers like the distance is too far, what can we do in the community? Have a chat with your social prescriber. What stuff can we help people doing to get them back doing their activities they love and enjoy? Is it the fact they want to somebody to go with them? So what can we do about that? Can we get a friend or family member to help go with them, or do we need to get somebody like a little group? There's I Care I Move in Cornwall. They do virtual, so it's not
Brilliant.
for everybody, but it's virtual.
Yeah.
But they also do local. I think I can't remember off the top of my head where they visit, but they do local visits. Memory cafes will know about them.
Yes. And
Yeah.
so what we can do, Paul, is this is what I remembered now when I was saying I'd forgotten something, is put all these recommendations, the links you talked about around the people that are coming potentially to the Dementia conference. You also mentioned two people after that, or two organizations after that, to do with spatial awareness and yeah, I mean, I'll listen back to the recording, can't I? So we'll all be there. But we'll saying to everybody, we'll put all your references in the show notes. So there's a lot you can explore. So the next question then I might ask is depression. Is there something around depression that we could talk about in falling?
Yeah, it's a bit of a double-edged sword, depression. So if you had depression, so we know depression in the early and the moderate stages of dementia is quite high. So with depression, it affects your cognition, just even if you didn't have dementia, but it affects your cognition, it affects your function, your ability to do stuff. So we know, they say if you had depression and you compared it with somebody who didn't have depression, the person with depression is 50% more, I think it's 63% more likely chance to fall than somebody who doesn't.
Wow.
However, if you were to take antidepressants, by taking antidepressants, that increases your risk of fall. So we know having depression, but also the medication for it also increases your risk of falls. Interestingly, though, we know that the antidepressants don't work as well with somebody with dementia than it does if you didn't have a cognitive impairment. So we know it's not as effective. So it's thinking about what other things can get rid of that dementia with somebody with dementia. So we call it like complementary therapies. So being active is a really good way of doing it. Looking at your diet, getting rid of like your alcohol intake, increasing your fluids, but other things like arts and crafts, like arts, well, really super. Other things that you can do rather than medication to get rid of your depression. Family and friends are just amazing for support as well.
Yes, so socializing, having a hobby, getting out, eating well. Yes. And
It's a
it's
horrible
interesting
double-edged
because
sword, isn't it?
it's a double-edged sword, because I
Yeah.
think a lot of the time with depression, the whole thing is that you don't want to do anything, and it's you need to be, encouraged a lot to,
A big thing as well. So I said about the risk for the person with dementia. They did another study where they looked at carers, but 30% of all carers for the person living with dementia will have depression as well. So it's high amongst carers. So it's not only our people with dementia, it's the people who support them as well. So thinking about them as well. So
yes. And that's where places like Sensory Trust, I think that's so lovely, isn't it? And just there's some amazing things out there. Go on, what were you going to say?
Yeah, I was going to say lots of things in the community. It's strange because when we go down and do dementia training events, and then we go to like the village halls, the amount of things that are up there that you just like, some of them are, what did I see, clubber size, so you like club music and dancing and stuff like this. It's random stuff they'll do, but that's where you'll find lots of things in your local community. Social prescribers will be another good one. Your local, your memory cafes will know what's going on.
Yes. All right. So we've got one more question then, is how important then, is there something that carers can do? How important is it that what carers can do around the home, or any advice for carers listening if they're really worried about their loved ones falling? What would you?
So we know carers are like paramount for supporting people who fall and with dementia. There was a study in America that looked at people who lived with their spouse were 200 and I think it's like 50% chance more likely to fall than if they lived alone. And you think about, so why is that? And it's because if you were living on your own and you were falling, you were not likely to be living on your own for long. You're more likely to be going into a care home. So it's like looking at placement for yourself. So it's really, so we know people who have somebody with them that are falling, say like a carer with them or their family member, they're able to help them back up. They're able to keep them in their own environment for longer. So they are like paramount. They'll do lots of things like reminding people, oh, you've got your GP appointment, you've got your this, so looking after not just your dementia, making sure you're on top of your dementia, but all your other like health conditions that you might have, being on top of them, being like what we call optimized to live a good quality of life. They might be just walking with somebody to say, not like holding their hand or anything, but just say, oh, mind that step, or
Yeah.
watch that turn here. So they do so many. It's the like sometimes it's the tiny little things, but it's the big things as well, like looking at how to keep them in good health. Well,
That's brilliant.
modifying the environment, and we all know, what do they say? I like to give facts and figures because it then it shows people. So I swear it is carers save like 20 billion or something of the UK economy, because we know that they might, exactly, because we know to get carers to come in, so to live with somebody in their own home or to have somebody in a care home, costs the system huge amounts of money. So they might have to then, I'll reduce my hours at work. That's a massive choice they've had to take on. I'm not going to do things that I enjoy as much. Am I going to work that identity that I had to support my loved one? So we know they do a huge amount for people, and it's also we need to look after them as well, don't we? Look after our carers.
Absolutely.
So what is it that they need to be able to do? And ProMass are super for that, because they'll have looking at like carer well-being, but also carer activities, keeping them engaged, and then the peer support. So it's great that carers can come and chat to a healthcare professional, but it's much better for them if they can talk to somebody else who's in that situation, who's always been in that situation. They can bounce
Yes.
ideas off, how did you deal with this?
Yeah, because it's so isolating and you can feel unseen, can't you? You think, like you say, you've let go of a lot of your own life to support your loved one. And it can feel, especially if somebody's living with dementia, it can feel quite a thankless thing. So, as you say, making sure that we really see the carers and support them to have some life as well.
Mm.
Oh, this has been
Was it,
fascinating.
or they become frail in themselves, and then they become a false risk
Yes.
because they then isolate themselves, don't go out and do the activities that they need to do, or go out doing the shopping
Mm.
because they have to look after their loved one. Yeah.
And they
So
worry so much leaving, even when if they could leave them for a few hours, it's that anxiety, that separation anxiety,
mm,
because the responsibility so much.
there was one thing that I was going to say as well. We used to call it wandering, but now we call it like walking with purpose. So sometimes with people with dementia, they might not be able to express what they mean, but they might go for a walk at 3 o'clock in the morning. But at that time, at 2 or 3 o'clock in the morning, they might be thinking, I need to go to the shops. Okay, so they've got that purpose. So they're walking with purpose. I would say, Dave, we need to encourage that. So by them walking, okay, they are keeping themselves active. If we are going to start saying stop doing that, they just become weaker. So we used to see it quite a lot in
Mm.
hospital with people saying sit down, sit down. All that will happen is that person's going to get weak in the legs. So therefore, the next time they get up and walk, it's going to be a lot harder. So we've got to be thinking about how can we make this as safe as possible. So we know walking at 2 or 3 o'clock in the morning isn't the safest thing. So what can we do? Can we look at the environment they might be walking in? Can we let people know, say, for example, they usually walk to the shop, and say if it's like a 24-hour shop, you might be able to tell the person behind the till or the attendants that this person might come in, they've got dementia. So they're aware that this person's need. That's where like that being a dementia friendly community is really like really
Massive,
yeah, exactly, isn't it? But there's
massive.
things like technology is super, so you can have they like electronic tagging. It sounds like they're criminals, but it's not. But it's like a simple thing that you could just put a bracelet on or put it in their handbag if you're not taking the handbag out.
Or a
Um,
pocket.
exactly.
Yeah.
Some people I like to touch on some of like the taboo subjects as well. So locking somebody in their home. So we know
Mm.
this happens. We know this happens because, say, for example, with my granddad as well, he went out at 3 o'clock in the morning. It's quite lucky that a few of them he lived in, this was Totton in Hampshire. He lived there for 30 odd years, and so people knew him. And so if they saw him out at 6 o'clock in the morning, they'd usher him back home, get him safe and supported.
Yeah.
We didn't have like air tags back then, but that would be something that we could look at, or you can have the gateway controls on doors. So if you know the door's been open, it might alert a family member going, what's happened here? Or they've
That's
been
a good
outside for
idea.
more than 10, 20 minutes. You might then get a bit more concerned. There's the Herbert protocol.
Yes.
So for somebody who likes to get out and walk, and having one of those is really, really helpful. But I'll go back to that locking the door thing. So what we'd want to do, say if you were to say to someone, you're a healthcare professional, you're a primary care dementia practitioner, I'm really concerned that he's leaving the house, I've locked the door. They would go, okay, you're thinking about this is the posh word is depriving somebody of their liberties. Okay, so they're not able to go out because somebody else has locked the door. Now they might go and say to the person who's being locked in, are you happy with that? And it's yes, because I know I've gone out and walked 6 o'clock in the morning, and it might stop. It makes me stay in my own home for longer. Yeah. Okay. So then you're like, okay, they've consented, type of thing.
Yes.
If they weren't able to consent because they couldn't think of that, they didn't have the capacity, they weren't able to make that decision, you would then do what we call raising a safeguarding. Now this makes safeguarding, but sends shivers down your spine, doesn't it? It's a terrifying type of word. But it shouldn't be. It's just basically, we've got a concern that this person's being deprived of their liberty and they can't consent. The person would then do like a risk benefit. So the risk of them is this: they'll be locked in. If there's a safety thing, say for example the fire, what can we do about it? The fire brigade aren't going to get there any quicker, but if we tell the fire brigade the door is locked, they'll know somebody's in the property, so they'll go in prepared. So that's one of the things you want to do if you were locking somebody in, is tell the fire brigade, they'll know somebody's in the property.
Okay.
But then they'll say, the healthcare professionals go, right, okay, so we know that you've been locked inside, they can't make that decision. What is the alternative? You've been locked inside, the risk is the fire, some other safety things. But the benefit is you're staying in your own home, and we know that most people want to stay in their own home for as long as possible. So you're just weighing it up, and that's how the outcome of that safeguarding might go. So that you're letting people know.
Or the other thing might be that the risk assessment or the risk safety would be, well, it's okay for that person to go out, and it's more about the carer's concern. And
that's it. And then what can we do? The air tagging or the electronic tagging. What else can you do? There's so many little things we can do. What we'll do, there is the really good Alzheimer's Scotland leaflet on it, and we'll link it in this as well.
Thank you. And also I spoke to Julia Berry, who is the community police officer at Helston, and she said they've got a new thing that's and we've got a video about this. She said that it's like a neighborhood watch on WhatsApp. So you join it in your local area, and then text messages come up. So for example, if your loved one has gone off for a walk and you don't know where they are and you're a bit worried, you would inform the police community app, and they would, like the Herbert protocol, they would already have a description, and that would go out to anybody within the community that was part of that app, and then everybody would be looking.
Sounds fab, doesn't it? That's
so
lovely.
Cool. So it's all these things, isn't it? Yeah.
Quick message, everyone's aware.
Okay, so anything else before we finish? I mean, it's been fascinating. I've learned so much today.
And I'm happy if people want to email me, so put my email in if you do have questions. But it'll be first point of contact would be like your GP, your district nurse, or anybody that comes in that's like a healthcare professional to your home. Let them know.
Amazing. Thank you, Paul. It's been brilliant.
No worries at all. Thank you very much for having me.
Oh, thank you.
This video was produced by Discover Voices, part of Disability Cornwall and Isles of Scilly. To check out all of our content, simply search Discover Voices on YouTube.